Hello, this is Mrs. Condry. This is problems of oxygenation for obstructive pulmonary diseases. Our objectives is that we will look at the differences in treatment and signs and symptoms of asthma and COPD, which we see all the time. Asthma, I'm going to first do this slide and then go back to the picture. What is asthma? It's a chronic inflammatory disease. It results in bronchoconstriction, hyperreactivity. So any allergen, they can hyperreact and have edema, and they can have mucus in that bronchi. So here's a normal airway, and here's where they have asthmatic symptoms, where the airway is very narrowed, and that's why we're hearing wheezes, because it's air trying to pass through that tiny little bronchi, and they have difficulties. So the risk factors are genetics, environmental factors, such as getting exposed to pollution, smoke, male gender before puberty and female gender after puberty, and obesity. Then those triggers are allergens such as molds, pet dander, cockroaches. Another theory that why asthma may be increasing in the United States is because we as parents are afraid of germs. We're afraid of germs, so we protect our children from germs. But asthma is increasing. It may be because we've been too vigilant about protecting our children from germs. They need to be exposed to, I grew up on a farm. We got exposed to hay, to animals, and some people are afraid to expose their children to it. And then they can develop an allergic reaction. So it could be irritants such as cigarette smoke, dust, chemicals, and air pollutants. And a trigger can be exercise, a history of allergic rhinitis. So someone who has allergies in the first place can be more likely to develop asthma. GERD is where you get a reflux of stomach acid, so constant irritation sometimes may cause some aspiration and cause that acid is a foreign substance into the bronchi. And it can be allergy or sensitivity to certain food or drugs. So the signs and symptoms of asthma are wheezing, a cough, dyspnea, chest tightness where their chest is really heavy, possibly prolonged expiration, so you might hear a wheeze in, and then just a long wheeze trying to get air out. Acute attack, they have signs and symptoms of hypoxia and wheezing. And if they have severely decreased breath sounds, they may that may be a sign of acute respiratory failure. Asthma can ebb and flow. It can be intermittent. It can be mild, persistent, moderate persistent, and severe persistent. So it depends on the frequency of the symptoms. It can rapidly progress from normal breathing to life-threatening, and actually can cause death if they didn't get to the hospital in time. So diagnosis is through history, a pulmonary function test, which remember I talked about in fundamentals, where they see how much the patients be able to hold in their lungs and then be able to exhale. Peak flow test, which is just a small little device that can check for peak flow. A chest x-ray, allergy skin tests, blood levels of eosinophils and IgE, which are those cells that show allergic reactions, and pulse oximetry. This is a step treatment of asthma, where here's intermittent and here's persistent, that require daily medication. So the patient can be stepped up in the treatment, and they can also be stepped down. So this is unlike COPD. COPD usually they continue to to progress and get worse, whereas asthma can wax and wane. So do look at this, especially when we are doing pharmacology. Nursing management is very important for education. Education is so important with asthma. All the classifications require a rescue medication, and those with persistent asthma require a long-term medication, such as an inhaled corticosteroid. And then we need to teach the correct use of inhalers and nebulizers. With a spacer, the studies show that it is just as effective using a spacer and inhaler as a nebulizer. So that's important to teach. A peak flow meter, important to teach, to check that daily to see how they're doing, if they're able to exhale. We need to teach the patient to write an asthma action plan, to make those plans. If I am doing this, I need to call a doctor. If I'm doing this, I need to call 911. And teach ways to manage their attack to decrease that sense of panic. Because of course, if you can't breathe, are you going to panic? I would. So we need to teach ways to manage that attack. And of course, administer oxygen is needed to keep O2 sat above 90%. So normally with asthma at home, they don't have oxygen, whereas COPD, they often do. So if they are hypoxic, they need oxygen, and they would need to be hospitalized. Drug therapy is rescue versus long-acting medications. So the rescue inhalers are bronchodilators, and there's a short-acting one and a long-acting one. So the short-acting one is really the one I classify as rescue inhaler, and it's a beta-2 adrenergic agonist. Albuterol is the most common one. It lasts 4 to 8 hours. And these are the long-acting ones, salmeterol and formoterol. Those last up to 12 hours. But if a patient's having an asthma attack, they need to use the short-acting one. These increase the mucociliary clearance. So we have little cilia inside our bronchi, and it helps to move mucus out and prevent bacteria from coming in. So it increases that, and it helps to dilate, open up the bronchi, and prevent bronchospasms with exercise. Often what's combined with this beta-2 adrenergic agonist is this drug, the anticholinergic, I don't know how to say this one, ipratropium. These are often combined like duonib or duo inhaler. This helps to block the bronchoconstricting effect of the parasympathetic nervous system. It's not as effective as a beta-2 adrenergic drug, but combined together they work very well. Methylxanthines or theophylline is the only drug that is usually used now. It used to be a very common drug. In fact, when I was a new nurse, we used theophylline all the time. But it was found to have a lot of side effects, and it was also found not to be very effective. But some people might still be on it, so they need to be taught that these theophylline levels need to be monitored. Corticosteroids or anti-inflammatories can be inhaled, or it can be oral for acute exacerbations, and when it's very acute, they often can get IV corticosteroids. And of course, those who inhale them, they have to be taught that they have to rinse their mouth after the use to avoid getting thrush. Leukotriene modifiers are another drug that is used. It's not just used for asthma, it's used for in generally allergies. So leukotriene is a mediator that bronchoconstricts. So this oral drug blocks that effect. It's used as an adjunct. It would never ever be used as a primary drug. So it's good for people with allergies to help prevent it. So if someone has seasonal allergies, this is good to start right before allergy season starts, to help to slow down that allergic reaction effect. And Singulair and Accolade are examples of these drugs. So now we turn to COPD. So remember that asthma was a disease of the bronchi, whereas COPD is a disease of the alveoli, which are those air sacs. So what happens is the bronchioles lose their shape and become clogged with mucus, and the walls of the alveoli get destroyed, and they have fewer and larger alveoli, so they have less air moving through. So COPD is preventable because it's usually from smoke, but it is a progressive airway limitation. They have an inflammatory response in the airway and lungs, primarily caused by cigarette smoke, but it can also be from occupational chemicals and dust. It can be from air pollution, can be from infections, and some people have bad genes, and there is some people that develop COPD from that. It also could be from exposure to, like, mixing bleach and ammonia can cause this fume, toxic fume, and the person could develop COPD. Only 15% of smokers develop COPD, which is very surprising to me. But of course, smokers also get other diseases, especially heart disease, from smoking. It's characterized by loss of that elastic recoil, and it causes airway obstruction because of the increased mucus, edema, and bronchospasms. So the bronchospasms, even though I keep saying it's a disease of the alveoli, it does affect the bronchioles as well as the alveoli, whereas asthma is just of the bronchi. It's the third leading cause of death in the United States. So even though you see the terms emphysema, COPD is only one part of the global definition of COPD. So we used to consider sometimes chronic bronchitis and emphysema as the terms for COPD, but they're no longer using those terms anymore. Chronic bronchitis is cough and sputum production for at least 3 months in each of 2 years, but it's not considered COPD. The signs and symptoms of chronic bronchitis, or this is COPD, sorry. Signs and symptoms develop slowly. So a patient with COPD often starts with a cough, and they might get a little short of breath, and they might start coughing up productively. They might complain, I can't catch my breath. Or they might have a history of exposure to risk factors, and the symptoms are progressive. Over time, they get hypoxic, where the O2 sat is below 88%, and their PaCO2 goes up. So the diagnosis includes a history and physical, the pulmonary function test to compare airflow before and after a bronchodilator. So if they have good response to a bronchodilator, often that's one of the diagnosis of COPD, or the factors to help diagnose that. And they might have a 6-minute walk test, which measures the O2 sat walking and at rest. Smoking cessation is the key important thing, and then they should get a flu vaccine yearly and a pneumonia vaccine to prevent pneumonia. Drug therapies include those bronchodilators, which reduce dyspnea and increase the vital capacity, which is expired in that first second of maximal expiration. It's the bronchodilators don't work as well on COPD compared to asthma patients. They also will often get inhaled corticosteroids, the long-acting beta-2 agonists separately or together. No drug works better than another, and it won't modify the decline of lung function. So whereas bronchitis waxes and wanes, remember COPD will keep progressing. Oral corticosteroids are good for exacerbations, but should not be given long-term for COPD. I had a patient in home care that had long-term oral corticosteroids, so oral prednisone, for years and years and years. She was very thin. A lot of patients with COPD are thin because they just take so much energy to breathe and to cough that they're quite thin. And long-term steroids can cause osteoporosis. So I was doing chest PT, which is the cupping percussion to try to help her exhale, and I broke her lung. I felt absolutely horrible. So long-term steroid therapy has too many complications. So the complications of COPD is cor pulmonale, which results from pulmonary hypertension. It's a late manifestation of COPD. The treatment of cor pulmonale is to manage the COPD with a bronchodilator, low flow oxygen, and diuretics. And I know pulmonary hypertension, they've recently added like Viagra, those drugs, very low dose to help with that pulmonary hypertension. So that is a newer treatment. Acute exacerbation of COPD is managed with medications, oxygen titrated to their arterial blood gases, and they might even need BiPAP or CPAP to support their ventilation. They get so tired from trying to breathe that they need some extra support. But they actually may go into acute respiratory failure because they just might wait too long to get treatment. So acute respiratory failure is not discussed here. It's more in advanced Med-Surg. So you'll see that in the future. But you'll probably see patients in the hospital with that as well. Oxygen therapy does increase survival, increases the exercise capacity and their mental status. Because imagine if you have low oxygen constantly to your brain, it can cause some confusion. So it does help increase the ability to think, to talk. The complications, though, are combustion from smoking. I've had a patient in home care who smoked with her oxygen on, and she actually burnt her face. I talked about that in fundamentals, I think. There can be CO2 narcosis, where the chemoreceptors respond to CO2 and oxygen levels. Some COPD patients, which is just a small percentage, but it's like this high, there's this big thing out there that we all learned as the older generation of nurses and doctors and workers, that we can't give high flow oxygen because theoretically it will decrease their urge to breathe. But if they have acute respiratory failure, we give high flow oxygen anyway. It's very important. So the goal is an O2 sat of at least 90% or a PaO2 of at least 60. So O2 toxicity is if we give oxygen based on ABGs, but we leave the oxygen on like for days and days at a high flow, it can cause a severe inflammatory response. So yes, short term we give high flow if they're in acute respiratory failure, but we need to wean it down. And that's important. Like when you just see a COPD patient in the hospital and say they're on 4 liters and their O2 sat's 99%, it needs to start weaning down. That's too high. Other treatment is that we will need to teach a patient pursed lip breathing to prolong exhalation. So I want you to look in table 2813 and to see how to teach that. Often COPD patients have never heard of this, so it's important to teach that. There's also diaphragmatic breathing, which we can teach the patient to use their diaphragm instead of their accessory muscles to slow the rate and increase their inspiration. This is only for mild COPD. We can also teach huff coughing, which is a force expiratory technique, and that's in your book under page 569. Chest PT is what I was talking about with my patient because she was on long-term steroids. She had osteoporosis and very weak bones, and that's why I caused a rib fracture. But it's a very effective thing to help augment their postural drainage to try to get all that sputum out of there. There's also positive airway pressure devices such as Flutter. That's what this picture is of a Flutter device, and it helps to move the secretions out. Cystic fibrosis is a autosomal recessive gene. It's a multi-system disease. So even though we think automatically just affects the lungs, it actually affects the whole body. Every state in the U.S. has mandatory newborn testing for it. Initially, cystic fibrosis is obstructive due to mucus blocking the airways and with the chronic airway infections. So these are children that get admitted to the hospital often. In the past, they only had a life expectancy into their like 20s and early 30s, but now the treatment has been improving and their life expectancy has increased. It does progress to restrictive lung disease due to the fibrosis and the lung destruction and thoracic wall changes. The treatment is clearance of secretions with meds, and chest PT is important, and to control infections and to get adequate nutrition, because these children are very thin because they're struggling to breathe, struggling to digest, because they have abnormal pancreas function. They often get pancreatic enzymes to help improve that. Bronchiectasis is another restrictive lung disease, and it is a permanent dilation of those medium-sized bronchi due to inflammatory changes from infection that remodels the bronchi. The signs and symptoms are persistent cough with this thick, purulent drainage, and they have adventitious lung sounds. It's very important for them to get good hydration, to get rid of that mucus. They get antibiotics when they have infections, and chest PT helps in this case as well. So that is the end of obstructive pulmonary disease, and I will see you in pharmacology.